say? Oh.
What's that coronary stops?
Why is it showing y'all all of my business that my computer is not in compliance? Okay. Let me just go turn it off. So we were saying how we were gonna, like if we were gonna cardiovert, we needed to make sure that our patient was also okay with being cardioverted. We talked about some of the drugs when we said that pill in the pocket approach. And so we're just gonna review those, and then how we were saying, hey, we may need to anticoagulate that person before we do it, and potentially even after we do that cardioversion, okay? So this is just looking at some of the things that we talked about, summarizing. We had our beta blockers, calcium channel blockers, and our digoxin that we were saying we were using for our rate. Remember with your digoxin that this is not helping with our patients who have like that exercise-induced kind of thing, because if they have that sympathetic activity, you can still see that digoxin kind of becomes overwhelmed also, okay? Then looking at your rhythm, you have amiodarone and your 1C in class 3 meds. Amiodarone is kind of like a tricky one because sometimes it can also help with the rate also. So just paying attention to that is like your big overarching ideas. If I ask you about amiodarone, I'm going to put it typically with rhythm. Okay, so you have your rate and your rhythm drugs, and then talking about our anti-coag. If I'm going to anticoagulate that patient, and then whether or not you're going to say, hey, I want you to use some aspirin. Remember, that's platelet. We sometimes, depending on any other underlying conditions that they have, like if they have MIs, things like that, we'll add on our aspirin. Or I can just say, hey, I want to use one of my DOACs and anticoagulate my patient, okay? So those are our different things that we're looking at when we're thinking about trying to help our patients when we're cardioverting them. So looking at this, I have my DOACs, which is what is preferred. That's what I want you to remember from this. All those other things are different options that we have. Yes, do we typically use them? No. So for this and for testing purposes, if I'm asking you about anticoagulation prior to or potentially after us cardioverting, DOAC. Okay, that's what we prefer. Don't need you to go to all of your other lines. Other information that's on here, you have what's called a CHA2DS2-VASc score. When you have any patient that walks into your office and they have AFib, you're going to end up calculating their CHA2DS2-VASc score. When you do this, there are several different factors. There's calculators that you have online also to where you can plug this information in and get that score. What I want you to remember is essentially this picture down here. So if it's a male, they have 0 versus if it's a female and they have 1, they don't have to have anticoagulation. So women are penalized off the top. So we automatically get 1 point just for your gender. So if you look here at our CHA2DS2-VASc score and kind of where they're getting that and why we start that way. So you see where it says sex category female, they automatically are going to have 1. So that's why you see here, that's like their baseline, right? It was just because they were a woman. So you're 0 for your males, 1 for your females. You don't have to anticoagulate. When you're looking at 1 for a male and 2 for females, you can consider it. And then anything over that for the male or the female, they're anticoagulated. Okay? So 0 for a male, 1 for a female, you don't have to do anything. 1 for a male, 2 for a female, let's consider it. Anything over that, anticoagulate. And what do we prefer to use? DOAC. All right. This is looking at, again, us talking about that rate control that we were getting with our digoxin, understanding that when we're doing this rate control, your patients are usually going to be symptomatic. They're going to tell you, like, I'm feeling my flutter, I'm feeling that fibrillation that I'm having, okay? So they're wanting us to help treat their symptoms. When you're looking at your digoxin, most of the time this is added on to one of your calcium channel blockers or beta blockers to help further reduce that the symptoms that they're experiencing. Remember, narrow therapeutic index drug, very messy drug. We have to do a lot of work when we're using our digoxin. So this is like, you're going to try to get them on anything else to regulate that rate of any of our other drugs that we talked about. So our beta blocker, our calcium channel blocker, because those are more friendly to us. And then you're still saying, oh, you're still symptomatic? Okay, now I can add on that digoxin. And then looking at the additional heart rate control is what I'm telling you, right? So I've already had on my beta blocker I already had on my calcium channel blocker, I still wasn't getting the effects that I wanted to see, so I can add on my digoxin. I'm trying to limit how much digoxin I'm using, okay? Remember also lots of interactions. Avoiding in your patients who have WPW syndrome, essentially what that is they have this extra electrical pathway, right? And a lot of the times with those patients, they may be tachycardic and it can just cause issues with them. So one of the little other things to highlight about your digoxin. Looking at our beta blockers, our beta blockers and our non-DHP calcium channel blockers. What were our non-DHP calcium channel blockers? Rapamil and DILT, right? Diltiazem. So looking at these, again, just a quick review. We were talking about with our digoxin how it's not great for that exercise-induced symptoms that those patients are having. I'm more so looking at my beta blocker for those. Very, very good. So if somebody knows like, hey, I'm gonna go work out at this time, or I'm gonna go and walk around the mall with my friends, beta blocker, because I already know when that activity is gonna happen and they're expecting to experience those symptoms that they have. When you're looking at your stable heart failure, so this is a thing and this is a small word that's added in there that sometimes gets missed. When you're saying stable, right? If somebody isn't in acute decompensated heart failure, these are our drugs that we're typically looking at. So your carbidolol, your metoprolol, remember we're doing our XL, and then you have your bisoprolol that we were looking at. If I said that somebody was unstable, I'm telling you that they have acute decompensated heart failure, that's whenever I'm like more worried about using these drugs, right? They're not as safe in that situation. But if I'm stable and I'm just a person who has heart failure, I'm not acute, I'm not decompensated at that time, you can still see these are used. Adverse effects, we already talked about those. And then your non-DHPs, if you had to pick between one or the other, you would go with your beta blocker first, then your non-DHP, or if there's some type of contraindication as to why you cannot use your beta blocker, then we'll say, hey, I prefer this non-DHP and I'm going to use that. These were our pill in the pocket approaches that we were looking at, right, and talking about before. The big thing that I wanted you to remember with these is that we did that CASH trial and we saw that a lot of these drugs can be very pro-arrhythmic, okay, and worsening their situation. Most of the time when we're using this is for our patients who are symptomatic but not frequently, okay? So they can experience them, but it's not something that they're using all the time, right? This is like, hey, I'm feeling that flutter, I'm feeling stuff going on, pill in the pocket, I'm gonna take my pill. So same things that we already saw. We'll talk about structural heart disease, but essentially any type of condition that we could have with our heart that has caused some type of structural abnormality. I put different things down there. If I give you a question on this, I will tell you the person has structural heart disease. I won't try to make you remember like which condition. I'm just gonna tell you what it is, and you'll know what meds you can and cannot use. So we're not using our 1C in that patient with the structural heart disease. Looking at our class 3, here we have our amiodarone. What I want you to remember with this is that this is another one of those doses that I want you to look at. So remember that this has a loading dose of 10 grams. Depending on where you are, because of 10 grams being a lot, right? Like that's a huge volume. A lot of times we will try to load our patients orally instead of giving them IV, even though they may be in the hospital because it's a lot of fluid, okay? So 10 grams is what we're trying to do. It does take them a while to get there. The reason why I want you to remember 10 grams is because most of the time while we're loading our patients, they're not in the hospital the entire time, okay? When you're doing your med recs and they come, if you feel like they should be at 10 grams by the time that they come to see you, then you should be like, hey, how are you taking your amiodarone? Because as you see, what they're doing changes. So by the time they get to their maintenance dose, which is usually 200 milligrams a day, some people forget that because they've been taking that loading dose for a while, they forget and they will still be taking their loading dose. Okay, so then we're overdosing our patients. So for you as like a little note and kind of a clinical pearl, if you have somebody who is actively in their loading period, make sure that when they get out and they hit that maintenance phase where their dose drops, that they've actually dropped that dose. Because we have some patients where they're like, Well, I've been taking this dose for this long. I know I'm always taking 400 milligrams. Regardless of how many times a day they know that it's 400 milligrams, when we drop them down to that 200 for their maintenance dose, they're just programmed at 400. People don't read it, and they will continue to take 400. Okay? So make sure you're looking at that. The other benefit that we have is that this one we can potentially use in our patients who have heart failure. So our class 3, we're not too worried about that. Lots of interactions, all of the things that we were talking about monitoring when we went over the actual drug still exists. Looking at your dronedarone, remembering that this was like our alternative to our amiodarone, and it didn't have that iodine moiety in it, so we weren't so worried about the iodine. But we did lose some of the efficacy that we typically were seeing in our amiodarone, okay? So you have your sotalol also listed here, which is a better choice, just like our dofetilide, okay? When you're looking at your albuterolide, this one, just make sure that, again, they are being monitored. Any of these, when you're cardioverting, most of the time your patient is in the hospital and they are monitored. Remember that we had our separate ones where we were saying, okay, we have to admit them and they're going to be in the hospital for 3 days, but there's also still monitoring that day of. And that's how a lot of the times we can see our patients slip right back into AFib because we were monitoring them. They're going to be on a monitor. So just remember that you have that high risk with your albuterolide of that QT prolongation, and that's why we're worried about it, okay? Which one of these on here had the black box warning for being in the hospital? It's on the side. Sotalol. Remember, what class is our beta blocker? Class 2. But remember, your sotalol is your exception to that, right? So remember those things. Remember our class. We're going to be all right. And then our population. So you keep hearing me talk about, okay, somebody has heart failure, somebody has an MI, like what are we looking at, how do we treat these patients? Because this is going to be very common for you to see these special populations when you are treating your patients who have some of these arrhythmias. So your heart failure patients, we're typically avoiding our 1A and our 1C. Remember, you can kind of remember this as class 1, because our class B, we typically use those for what? Our lidocaine, our lisinopril, we're usually using those for pain. So if you kind of remember and you're saying, all right, class 1, heart failure, most of the time we're not talking about 1B anyway because we don't typically use that in this situation. Looking at this neutral effect, what you're saying here is I'm not going to have a lot of pronounced effects on, I'm not as concerned with mortality, like if I have a real mortality benefit or not. So these are our medications that we can use. You see your amiodarone, your dofetilide, and your sotalol. When you look at the chart that's on the next slide, you'll see that we should not be using dronedarone. So if you have a patient who has heart failure, do not give them dronedarone. Okay? Heart failure, no dronedarone. Okay? Your MIs. So again, we have our same classes listed here, showing that with our flecainide, remember the study, and it was saying, oh, these are pro-arrhythmic, these are potentially increasing the chance of our patient having mortality. So that's why we were trying to avoid some of these patients, especially with us looking at the 1C specifically, because those patients will have structural heart disease. Like I told you, I will tell you if it is structural heart disease that you're looking for. And then your neutral effect on mortality, again, you see your amiodarone and your dofetilide are going to be listed there as potential things for you to go ahead and use. So this chart is essentially everything that we just saw in words, but right here on paper minus our heart failure. So no structural heart disease, everything is fine. You see that you have your 1C and your class 3. Potentially you could use albuterolide, but there's several restrictions on it. Like they have to be seen and you have to catch it less than 48 hours, a lot of things, so that's why it's kind of not listed there because of the little nuances. So that's what you're looking at when you're looking at your drugs over here for your patients who have no type of structural heart disease. We'll save amiodarone, we'll try to leave that last. Looking at your ablation, that's if nothing else works, you can go in and you can ablate your patient. I'm not going to ask you about an ablation on your Pharm exams, okay? Now, structural heart disease, this is what I said. I will tell you that your person has structural heart disease, and then I will be more specific. Do they have coronary artery disease? Do they have heart failure? So this already will knock out some of your answers. Now we're going to sub-stratify that to say, is it the arteries? Is it their heart? So when I'm looking at my patients who have coronary artery disease, all of these you see that they're class 3 drugs. But here, I can use my sotalol, whereas with my heart failure, I'm not using my sotalol. There's a big difference in between the two. Also, you have your amiodarone higher up when we're looking at heart failure versus whenever we were looking at our coronary artery disease. So when I ask you these, I'm looking for the yellow boxes. Make sure that we're avoiding what drug that we just talked about in heart failure that starts with a D? Dronedarone. We don't see it here. There's no dronedarone here. There's no drones. Okay? Now, our challenge question. Somebody's taking amiodarone. What do we need to do? All of them. Make sure that you remember your monitoring. We get it at baseline, and we're going to check them. Yes. Okay? I'm going to follow up with them. This is showing you several different types of arrhythmias that you have, and then your drug of choice for them. So when we're looking at our bradycardia, bradyarrhythmia, so brady is what? Fast or slow? Slow. So our bradyarrhythmia, and they're symptomatic, so they're experiencing it. Your patient's probably going to be kind of hypotensive, they're probably going to have shortness of breath, they're going to be dizzy, they're going to have all of the things. I will tell you what they are, though. I will say they have symptomatic bradyarrhythmia. And so your drug of choice that you need to remember is that you're going to have atropine. We went over atropine. Remember that your atropine was your anticholinergic. So if you're talking about that, any of your side effects, which is what's listed in the comments, any of your side effects are going to be that they're just drying everything up. Okay? So that's all I want you to remember. I don't need you to remember this mechanism of action for how it's working. Looking at your PSVT or your paroxysmal supraventricular tachycardia. So if I'm looking at tachy, fast or slow? Fast. I have my adenosine. Do not mix these two drugs up. That's why I have them together so that because people will mix both of these up. So they start with A. They are working in two opposite ways, totally opposite ways, okay? So when I have my adenosine, remember this was like my on and off switch, right? So making sure that you're understanding this is slowing things down, all right? Fast on, fast off. I had to make sure that I was using, that I'm pushing this correctly, okay? Looking at this, I don't need you to look at the alternative treatments. This is talking about how you can like do sternal rubs, different vagal maneuvers to try to help that person get out of that arrhythmia. So I'm worried about here and here on this one, okay? Don't worry about alternative treatments. Not asking you that. When we're looking at our acute ventricular tachyarrhythmia or your pulseless fibrillation, drug of choice that you have is epi, and then if we're talking about specifically an antiarrhythmic, we have our amiodarone, okay? Don't worry about any of those comments. I don't want you to learn second, third, all of the things. I want you to know your first line for these arrhythmias, okay? Torsades. When we have our torsades, the big thing that we're going to use is that magnesium. They will have this IV. We also used our magnesium for our eclampsia. Remember our patients who were having seizures. So when we're looking at torsades can be an arrhythmia that is developed. Sometimes it is our drugs that does this to our patients. But when we use our magnesium, essentially it slows everything down for us. Don't need you to remember this dose or any of that over there, but I want you to know is that it is IV, it is not PO. It is IV, it is not PO. Because we have magnesium that we can also give orally, but that's more so if somebody is experiencing hypomagnesium, not if they're experiencing arrhythmia. We're trying to fix it fast. And then this is a list of some of our medications that we have that can cause torsades. Some of these y'all saw last semester and you forgot them already. And then we can see them here again, okay? What I want you to remember is like that class, right? So if I said an antiarrhythmic, for your antiarrhythmics, I do want you to know all of those because they're within this slide deck, right? But for your antibiotics, I will tell you the class. I will say it's a macrolide. I will say that it is a fluoroquinolone. For your anti-nausea, I would just say an anti-nausea medication. I don't need you to remember which ones. And then looking at your antidepressant, I will say it's an antidepressant. Okay, don't need you to remember which ones. And then for your anti-psychs, I will tell you that, and your migraine, I will tell you that it's a migraine. So the ones that I'm wanting you to remember the actual drug is going to be your antiarrhythmics, and then looking at your macrolides and your fluoroquinolone, just the class. I will tell you, like, this is a fluoroquinolone that they have or something. I don't need you to remember which ones were fluoroquinolones, okay? All right. What class of antiarrhythmic is lidocaine? 1B. True or false, Sotalol requires a week-long institutionalization monitoring whenever you start it.
False.
False. How long? 3 days. How do we give our adenosine? Fast. What else do we have to have when we give it on hand? What do we need to follow it by? Our saline flush. Why is that? Short half-life. Okay. How do we need to give it? Fast. Okay. And then remember, that was one of the other ones that I wanted you to remember the dose. So we don't typically do doses. So I told you about the Sotalol, and I also told you about your loading dose for your amiodarone. Okay? Those are the only two. I also wanted you, I don't typically say to remember formulations, and I wanted you to remember your magnesium is IV, not oral. Okay? All right. So we talked both. So remember, let me show you where we're at. Remember when we were talking here, and I was talking about our loading dose? So both of those, the dosing for both. Not, so let me be clear, just the loading dose that's involved, not this dosing schedule of how we're titrating it. What did I say?
You said so.
My bad. No. We only need to know the dose, I thought I said 2 days. We only need to know the dose for your amiodarone and your adenosine. Sorry. Thank you. My bad, y'all. Okay, that's it. All this other stuff is FYI. All right, let us talk about our statins so we can get up out of here. So our population is very, very healthy, and you're never going to prescribe these meds. Just kidding. You're going to prescribe these a lot. And I want you to make sure that you understand too that some of your patients may come in and they may look very, very healthy, and they may need these meds. Some people genetically, they have to have a statin, right, because they have high cholesterol. So when we're looking at this, we're going to talk about the different medications that we have. We prefer to use statins, but there's also several other drugs that we don't typically talk about. We don't use them as much because a lot of our people can tolerate our statins. Your ELOs are listed here. We'll do a little quick, what do you know? What is the drug class of choice for high LDL? Statins can be taken while pregnant.
No. False.
No, false. Okay? We'll talk about this, but they cannot. And then what class has the most triglyceride lowering effect? Not a statin. That's a good guess. That's why this is a pre-knowledge. We're going to talk about our fibrates, and that's what I was saying. Most of the time we talk about cholesterol, we hear statins, but there's other drugs that we can also use, and depending on what those labs say, sometimes we're targeting different things with our meds, but what we always hear is LDL. LDL is bad, LDL, but we're going to go through this and we'll see some other things that are listed. This physiology portion, remember, not on your test. Until we hit drugs, it's not on your test, but this is to let you know what our drug is targeting, okay, and why this is important for us. So when you're looking at this, we have several different lipoproteins. We have cholesterol and triglycerides that we need for our body. The issue is that when we have too much of it, okay? So that is where our drugs will come in. Sometimes, like I said, genetically, sometimes it could also be what I eat, what I choose to eat, and I'm causing this problem myself. But that is not always the case. So do not side-eye your patient when they come in there and they have high cholesterol, unless they tell you they eat horribly. Then you can side-eye. Don't side-eye. Okay? So we look at this. All this is saying is that there are lots of different things that some of them we need. Everything is in moderation when we talk about this. Okay, is what I want you to understand. Several different sources that we have of cholesterol. When we're talking about endogenous, this is what my body is typically making. More coming from the liver, and that's why we'll talk about sometimes where a lot of our patients will take their meds at night because that's when we have more of the cholesterol being made. And then you have your exogenous, which is me choosing to eat horribly, so my diet, right? And I'm putting this now into my body and causing the problem. So when you look at our statins and when we talk about our drugs and where they're working, we're typically targeting our HGM-CoA reductase. This is where your statins are working. If I can stop this, then I can stop this, right? I can then decrease the amount of cholesterol that I have. Okay, so that's where this is coming in. Like, do not remember all this stuff. Okay. Different lipoproteins. So we have our VLDLs, LDLs, HDL. HDLs are the only ones that we love to see. LDL, of course, we have to have it, but we don't want a lot of it. So most of our drugs are going to be targeting your LDLs, which is your low density lipoprotein, okay? Those are the ones that cause a lot of our problems, and then they're not going to be able to form more of our VLDL and our IDLs, which we don't talk about. Your HDLs, the higher the number, the better for our patient, but we don't use drugs typically to try to raise an HDL. You're never gonna, like, we'll talk about some of our meds where a side effect of the drug is that it does raise the HDL, but we wouldn't put a patient on a medication just to get a higher HDL, okay? All right, looking at terminology, because people use terms and sometimes they're wrong and they're not right. So when you're talking about your hyperlipidemia, this is just saying like there's a high level of lipids. It has lipid in the word, right? Hyperlipidemia. When you're looking at your dyslipidemia, this is just saying there's something wrong. There's some imbalance somewhere, okay? So you have elevated LDLs, you could have too low of your HDL. There's just some type of imbalance that is going on. So hyperlipidemia and dyslipidemia are kind of two different things, but people will say either of them, just so you're tracking like when you hear about it. Why we are worried, why we are trying to treat our patient. We have our arteries that we want open. If I continue to jam cholesterol into them, my water, like we like to talk about, my water cannot freely go through my water hose, right? So I start to build up and build up and build up to where now I have kind of started to occlude because I'm making this plaque, okay? So I want to try to prevent that from happening, and I want to try to prevent these plaques from forming because then I'm causing a lot more issues. So when we're putting certain patients on statins, we'll have a lot of our patients who have different type of cardiac issues. Some of those patients will say, hey, let's put them on a statin because I don't want to further restrict how their heart can function. I don't want to damage anything. I don't want anything else to be clogged. So we sometimes will prophylactically try to do this depending on what their risk factors are. Okay, exam time stuff, okay? When we look at our treatment, we're going to talk about several different categories. The biggest one that we're going to look at will be our statins. You're going to also hear several different guidelines. Different people use different guidelines. They continue to update the guidelines. Now there's a more recent one that is updated. So just look at that, make sure that you're understanding where you are at the time you are practicing as far as guidelines go. Like, is there a new one? Somebody also asked about guidelines and like, how do you find them? How do you know which one people want to use? Some people will pick one and that's the one that they always follow. And then the other thing is you can just Google it, like new guidelines for blah, blah, blah. And then it will tell you for any disease state that you want. And it will say like, oh, it's it's from 2016. And you're like, okay, that was a long time ago. And it's because they haven't found anything that's new that they need to update, so there's no updates to that guideline, okay? And then sometimes there'll be years that go by. Some we have guidelines that are updated every year. So when you're looking at this, just understand that we have different targets that you can hit, and we'll talk about this in the depth that I want you to look at it at in a little bit. So on this, I'm just letting you know that we have several different guidelines that you can use, and that is kind of how you find your target. I will tell you on the exam if somebody is high or if they are low. Okay. This is that risk calculator. So we talked about the ASCVD risk calculator. We can also use them, again, those same non-modifiable, modifiable characteristics that your patient can have. And so we'll say, hey, I need to see if my patient needs to be on a statin. Maybe they haven't had an event yet, but what if I'm trying to avoid them from having one because I put their labs in, I put all the information that I had about that patient and they're at a high risk, I may want to go ahead and start them on a statin. Okay? So when you're looking at this, this is kind of how you're going to stratify giving your patient a statin. This is your clinical use before we talk about all of the drugs, right? So if somebody has ASCVD, which we're going to talk about different things like that, if they have an LDL that's over 190, that's high, or if you have somebody who has a risk that is greater than 20%, and they're in this, like, I think about it as like they're in their prime, right? They're 40 to 75. They're not young, but they're not like old yet. Okay, so they're 40 to 75. All of these people are your patients where you're typically trying to say they would benefit from a high intensity statin. Your moderate intensity statin is where most of your patients are going to fall. Your moderate intensity statin between the ages of 40 and 75, you're also going to look at their risk as well to see if you're going to start them on the statin. So they're going to have ASCVD or they're going to have diabetes, and then you see that their score is greater than 7.5 but less than 20%, because you'll put it in the risk calculator. Okay? There's other patients that don't fall into any of these categories, and we just talk to them about lifestyle modifications. Keep pushing their diet. Don't eat horribly, all of those things. Okay? Those are the ones where you have to be a little bit more patient. The ones who you put on meds, you're going to have to be patient with them too, because you're going to put them on meds and they're going to keep eating horribly, and you're going to be like, why are you doing this? Or they're going to also not work out. You're going to say, hey, you know, these things can help. So remember to push those lifestyle modifications as well as our drugs. Y'all are going to have to remember this. And I'm not joking this time, I'm being for real. I know I usually be joking with y'all, that's why I've done it. Okay. So, but we just talked about it, right? This is like a really nice summary of this. Okay, I made another chart to try to not make you want to punch me in my face. So when we look at this, right, we talked about our LDL that was greater than 190, right? So we said that this person needs a high intensity statin. That's right here, bless you, right? That's right here. When you look at your person who has, bless you, diabetes, they're between the age of 40 and 75. They can deal with a moderate intensity statin, and that was right here, okay? We also have where if they're between the ages of 40 and 75 and they have diabetes, you can opt to put them on a high intensity statin. As we go through statins, you'll see why sometimes we don't do this. A lot of people will complain of muscle pain and they can't tolerate the medication very well. Think about your patients who have diabetes already, right? They already have pain. They typically have some type of neuropathy sometimes. So adding on something else is kind of why we're like, okay, I can consider it, but I don't necessarily have to. As long as they are on a statin that is typically a moderate intensity statin, I'm okay. Most of your patients are also going to be on either moderate or high intensity. That's the other thing. We don't use low intensity very often unless somebody can't tolerate my moderate or my high. Okay? Now, going down all of this other stuff. This is also looking at primary prevention. When I say primary prevention, that means that they have never had any type of event occur. I am trying to prevent it first. primary prevention, okay? Your younger patients, most of the time, we don't really deal with them. I'm not gonna ask you about them because typically if you're trying to start them on a statin, they have some type of genetic issues that are going on, and you are gonna end up referring them. So you don't even need to worry about this because I'm not gonna ask you that, all right? When you're looking at your age, 20 to 39, and they're typically okay, they're not having any other issues going on, their LDLs aren't ridiculously high, all of the things, I'm typically just talking to them, so I'm not really gonna ask you about this person, okay? That's like where I'm telling you to consider a statin if they have a family history and all the stuff, I'm not gonna ask you that way. This is where I'm gonna ask you, okay? So, 40 to 75 years old, typically we want to have a target LDL of less than 70. So if this person is over 70, but they're less than 190, because remember when I'm over 190, you're giving me my high intensity, right? So this person, they're over the goal of what I typically want to see of 70, but they're not horrible at that 190. So then I need to say, hey, I got to stratify you. And the reason why it says, where it says without diabetes is important because remember, they were on the side. They were already getting that moderate and I can consider a high. So that's why this is, again, separating the without diabetes. So when I have this person, that's when I whip out my ASCVD risk calculator, okay? I'm gonna put it in and it's gonna spit out a number to me. When it gives you that number, that's where you're saying, all right, now I know what I'm gonna give. Now I'm gonna pick one of my statins, or I'm not gonna pick anything at all, and I'm just gonna talk to them. So when I'm looking at my low risk, this is my less than 5, I'm not asking about them, right? They're good. We talk to them, we encourage them, lifestyle modifications, all of the good things. When I'm looking at my 5 to less than 7.5, this, I could potentially put them on a moderate intensity statin, but that's if they have one of these risk factors that's listed over here. If I give you a patient like this, I'm going to tell you it is a risk factor of whatever it is. I don't need you to remember all these risk factors. I will tell you that it is a risk factor. If you see that they have that risk, a risk factor, then you can consider putting them on that moderate intensity statin. Now, where your big conversations come and where the lifestyle changing conversations come is when you're in that 7.5 to 20 range. These patients, they are getting a statin. We're giving them that moderate, sometimes high, depending on where they are, but we're giving them that that moderate intensity statin, okay? And then this is looking at your risk discussion for your patients who have super high. Of course, we're going to put them on a statin, and we're going to put them on a high intensity statin. And this just says initiate statin, but we're going to put them on a statin, high intensity. Okay? So, bless you. If you look at this is essentially the same thing as what this is saying. I just tried to simplify it and make it not so risky. Okay? So I said that if you're looking at this, 1, 2, 3, these are your exceptions, right? Everybody else is falling in your 40 to 75 range. If I hit them and they're in between that 70 and that 190, I have to use my ASCVD risk calculator, and then I'm going to stratify them based off of their risk. Over here, I don't care about an ASCVD risk calculator. If my LDL is over 190, if I have diabetes, I'm getting a statin, right? You don't have to go and put in anything. You're like, here you go. Whereas these people, you're trying to say, how bad are you? How bad are you for me to give you a medication? Okay? Yes, no, maybe. Y'all mad? Yep. Yes.
For that number 3, is it just saying that if they're over 75, you're going to give them a statin?
So this is saying if I'm over 75, let me live. Don't put me on any meds.
Okay.
Just let me go out. No. So what it is saying, it is kind of saying that, right? So what it's saying is like, what is the risk versus the benefit? Because if I do put this person on a statin, I'm old. Raina has lived her life. My muscles, everything is already hurting, and you want me to take something every day, I'm likely to see the myopathies and the side effects for my meds because this person is very old. So you have like a risk versus benefit kind of conversation with them. Sometimes what I have seen is that we'll start them on like a low intensity statin, so they're on something. But if they hit the age of 75 and they've been on a statin, we don't take them off. We will leave them there and say, well, you've been tolerating it, it's fine. But if they are over the age of 75 and we're like, oh, your cholesterol is high, then we're like, like, are you on your last leg or not? You got, how much gas do we have left in the tank? So it is a very intimate conversation, and sometimes they may say, like, I want to try because I do want to live to be 100, or I might be like, you know what, it's fine, I'm not, let's see how long I can ride this train, right? So that's where that conversation comes into play. It will be your judgment, you trying to either convince them or be like, you know what, this is an option that we have, and like I said, most of the time we'll do low intensity. Very rarely will we be like, here, have this high intensity statin. Okay? Very good question.
Yeah,
Yes.
I just want to clarify, so for the diabetes in the age 40 to 75, you said go ahead and do high and do moderate if they're having side effects with their skin.
So, I'm a very aggressive, and we should, like, as this continues to get worse, more people are becoming aggressive with treatment. The issue is the side effects with your high. So it's like, if I ask you this, it will be kind of like I will lead you to where you need to go if I ask you a question about this. But per what you are supposed to do and per this chart, they have to have a moderate. They don't have to have a high. That is like a preference thing, yeah. Okay, so great question. The yellow is like, oh, I'm kind of like, I'm iffy, I can have a conversation with you about it. The green is, this is where we found the most evidence, this is something that you're doing. So for your diabetic patients, on an exam, look for your moderate. I will just leave it at that. Look for your moderate if you have that for an exam. Okay. Okay. Secondary prevention. I messed up, right? I had some type of ASCVD event. I didn't come and see you first. So now you're trying to prevent me from having another event, okay? So this is the difference between your secondary. The way that I want you to look at this is understanding these people who are very high versus they're not very high. I will tell you they're very high, or I will say they're not very high risk. You just need to know which side of the chart you're going in. So if they are not very high risk, I have a high intensity statin if they're less than 75. If they're over the age of 75, then again, I can look at this now. I have already had an event. Again, it is a conversation, so that's why you see it as yellow. But what I want you to remember is we're talking to them about potentially having a moderate or a high intensity put on board. If they were already on it, again, we will keep them on that medication. We will not take them off. Okay, so moderate to high intensity for your over 75, okay, is what I want you to remember, because that's how I will ask you that. If you, bless you, if you are less than 75, then you're still looking at your high intensity, okay? They have already had an event, therefore I'm a little bit more aggressive. When I'm looking at my very high risk, I will tell you that they are very high risk. When I look at my very high risk, you have a statin. You're going to get you a high intensity statin. Why you see or maximal statin is because, again, you will try to have them on that high and they may not tolerate it. They may experience a lot of side effects. You want them on something versus saying, I get these myopathies, I get all this pain, and I'm not taking anything. Okay? So that's why it's kind of like you're negotiating. You're like, all right, I'm going to put you on this high intensity, you're going to see how they do. If they come back and they're complaining of like their pains, then you'll be like, okay, I'm going to back off a little bit. And like they'll slowly start to back off. We'll talk about different things that you can do to kind of play with their dosing. Okay? So this is what I want you to look at here. When we talk about this, we're going to go over us adding ezetimibe to their treatment. So we see it over here. You also can see it in this in our very high risk as well. So what ezetimibe is ezetimibe is like our next step after our statin, where we're trying to control our patient because we can't control them. Or we will sometimes use our ezetimibe in our patients who can't tolerate a statin. Even when we put them on a very low dose, they can't tolerate a statin, you'll sometimes see where we'll do the ezetimibe. Okay? So if you're looking at this, what I want you to think about and what I want you to remember is all of your patients are not going to come in and look unhealthy. We had this guy who came in and I was like, oh, he's about to rip his shirt. He looked like the Hulk. And I was talking to my preceptor and I was like, why is he here? He was like, oh, he has high cholesterol. I was like, what? He's like, yeah, it's genetic for his family. And he's like, and he can't take any of the statins. They're he's very sensitive. He ended up getting rhabdo while he was taking the statin, probably also because of how much he's working out. And so we ended up having to go through several different things as to and document. We had to do prior authorizations, medical necessity forms, and so we just put him on ezetimibe, and as they kept going, I left before I figured out where they kind of needed him at. So just understand that this is like the icing on top of our cake, right? We're trying to make sure that we can get our patient controlled because we're not doing it fantastically with our statin, or they can't tolerate it. Okay, we need lower LDLs because we're still not reaching our goal of less than 70. Okay? All right, let's take our break, come back at 2, and then we'll have our break. These are our categories of drugs that we have to help control those horrible LDL levels that our patients may be having. Some of these will also help us with triglyceride levels. So when we're looking at these are going to be your drug classes that you have. So your HMG-CoA reductase inhibitors. And then you have your ones that are going to focus on your lipoprotein metabolism, your BASs or your bile acid sequestrants, and then your cholesterol absorption inhibitors, which you will also see sometimes abbreviated as CAI. Okay? So when we're looking at these, just understand that you're trying to say, hey, I am trying to get this person who has some type of dyslipidemia back under control with all of these different meds. Most of the time, we're going to be here, and this is effective enough to where, and hopefully your patients tolerate a statin, and we're good to go. We don't have to go through all of these other things. This is a summary chart, and this was kind of one of those your knowledge check questions of, hey, what has more effect on what, okay? So if I have LDLs, HDLs, and my triglycerides, these are good in moderation. This, the higher the number, the better. And then this, I'm like, good in moderation also, right? So I have my drugs on this side, my statins, fibrates, niacin, BAS, and my CAI. If I'm looking at LDL, the best thing that I have for LDL and to target my LDL is my statins. The best thing that I have for my triglycerides is going to be my fibrates, okay? We already talked about my HDL. I can get great benefit from some of my other drugs, but I'm not using them because I want to increase someone's HDL, okay? This is just kind of like a byproduct, like, oh, wow, I get an added benefit from my HDL going up. But that's not why you put somebody on the med. So you see your niacin is also good for your triglycerides, but as we talk about niacin, you'll see why, for the most part, we use our fibrates, okay? So, this is another thing that is very, very important, and I learned this the hard way. You're going to have to know what is high, moderate, and low intensity. The reason why is because you're going to have all of these things, right? And you're going to have all these drugs available to you. What you're going to notice is that your high intensity are the same things, some of them are the same things, your rosuvastatin and your atorvastatin. The only difference is it has a higher dose, okay? But those are your only two for your higher intensity. So I think about like an AR, right, is a high intensity. Now the next thing that you need to remember is, okay, what is my strength that I have? So this can sometimes be annotated depending on what kind of chart you look at. They may say 40 to 80 milligrams. This is just telling you the way that they did the study. The ones that are in parentheses are the ones that they studied, and so that's why you see that, but just remember the range, 40 to 80. Anything that is over 40 for atorvastatin, high intensity statin, okay? Anything when you're looking at your rosuvastatin, which we also call our Crestor, anything that's over 20 milligrams, high intensity statin, okay? Then I will try to remember my low, okay? So looking at your low, This is the one that we don't use very often. The only time we're kind of reaching for this is my patient can't tolerate my moderate or my high. They're having a lot of side effects from my moderate or my high. I may end up trying to go into my low intensity statins. Or if I have a patient where their LDL is kind of close to goal, and I just need to give them a little bump to get there, okay? So that's the other thing I wanted to point out. You don't need to remember this part though. But this is where you can see how much they're decreasing their LDL by, okay? So that's what we are expecting to see. This is like our return on our investment, okay? So I'm expecting with a high LDL that I'm at least gonna get a 50% drop in their LDL levels is what that's saying, okay? So when I'm looking at my low intensity, most of the time our people are not gonna be close, they're usually very high. And we're like, got a lot of work to do, okay? So that's why we also don't use this that often. So less than 30% is what we're getting back from these. So simvastatin, 10%, and then you have PLF. So your pravastatin, lovastatin, fluvastatin, okay? When you're looking at these, your pravastatin, lovastatin are also, and your fluvastatin are also in your moderate intensity. So I would just remember these are between 10 to 20 milligrams. None of these are really going over that except for your fluvastatin. And then your moderate is everything else in the middle. So if I were studying for this and how I study for this is I do my high and my low because that has the least amount, and then I say everything else is moderate because I'm not going to make up a dose. I will not make up an imaginary strength and expect for you to know what that is, okay? So remember your high and your low, and then understand that everything else is kind of in between. I can't say that. Remember your high, remember your low. I can't. Guiding a little bit too much. Yes.
Is there anything that's easy to top box or bottom box, like the top box more primary?
No, don't worry about it. No. But essentially, yes, a lot of the times what you're going to see is you're going to see Crestor used a lot now. A lot of people are no longer using simvastatin that much because they have the side effect profile, and a lot of people are having side effects from it. So for the most part, you'll see people using the atorvastatin and the rosuvastatin. I guess I can help you out a little bit. I will, if I'm looking at moderate intensity, I will pick a atorvastatin or rosuvastatin. Just remember those two doses. And look at pitavastatin, and we'll talk about why you may need to know about pitavastatin. Okay, so atorvastatin, rosuvastatin, and pitavastatin. All right, for your moderate. Just remember those three. That's still a lie. Okay, yes, you're right. All right, so mechanism of action. The mechanism of action that I want you to remember for statins is in the name of the actual drug. Is everybody clear on what we're looking at on this other side? Just so we make sure everybody's following on what we're remembering. So for my moderate, I'm looking at my atorvastatin 10 to 20, my rosuvastatin 5 to 10, and then pitavastatin. Okay? Don't worry about trying to stratify the doses and all the other ones in between those. Okay. So when I'm looking at this mechanism of action for my statins, essentially what they're doing is they're trying to stop that reductase. That is in the name of the drug, like the drug class, right? So if I stop that reductase, my idea is that I'm going to have less intracellular cholesterol, which is my problem. I don't want the cholesterol. Then what you'll see is that you have an upregulation of your LDL receptors. So if I have more receptors to say, hey, LDL, come over here, right? I am now getting it out of circulation because I am going to bind it. So I have less LDL floating around in my plasma, causing problems. This is what your mechanism of action is for your statins. All starts with you targeting that reductase, and then your end result is that you're going to say, I have less cholesterol. I have pulled all of that LDL out of my system. It's not floating around anymore. I have decreased the circulation, the amount of circulation that I have, because I was smart and I upregulated my LDL receptors also. Okay? Clinical use, drug of choice, we already talked about for our patients who have high LDL levels, and then off-label for our kids. Typically, these are going to be your children who have genetic issues as to why you're going to use this or see this used in anyone who's under the age of 18. So typically, we do not use statins in our kids, and that's the one that I told you on that chart. I wouldn't even ask you guys about using it in that population. So what I want you to remember, not for our kids under the age of 18. Looking at our clinical effect, sounds very repetitive. Look at the bold. You're trying to decrease the amount of LDL that they have in their system. I'm trying to take it out of circulation. If I do that, I can decrease several different events that could potentially happen. I can decrease mortality. I can decrease the chances of someone having a stroke. So we're getting a good mortality benefit from these drugs, okay? And I'm preventing a lot of different coronary issues from occurring in my patients. When you look at your dose, this is something that you are going to hear. The older someone is, the more likely they're going to tell you that you need to take it at night. Yes, we have more cholesterol that is being made at night in some of our patients. You can just tell everybody like, hey, if you want the maximum effect, yes, you can take it at night. But when we're looking at our when we're looking at our moderate intensity statins, that comes into play more so than if you're looking at your high intensity statin. Your high intensity statin, we don't care what time they take it. It's such a high dose that it's going to work no matter what. So when you hear that, yes, it's partially true that they should take it at night. But if they have a high intensity statin, it doesn't really matter what time they take it. Okay, it's gonna do its job. Looking at when you're monitoring your patients and when you're gonna increase or decrease a dose. When we talk about decreasing the dose, it depends on why you're having to decrease that dose. If you're looking at your labs and you see that CK has gone up, that's when you're like, okay, I'm not going to wait for 4 weeks. Other than that, if 4 weeks pass and they're saying like, and you come back, you're bringing them back in for labs, and you still don't see a good reduction in their LDL, that's when you can increase the dose. But you have to, again, I tell y'all to always dig. Ask them those questions. Are you taking your medication every day at the same time? Because they might tell you, no, I'm not taking my meds. So don't increase the dose. We need to get them used to taking their medication every day, okay? So make sure that the underlying reason as to why you're changing that medication is because the med isn't working, not because the patient isn't taking it, okay? So at least 4 weeks before you up their dose, if we're not getting the response that we want. Now, your big adverse effect, which you keep hearing me talk about, is going to be in all of these different muscle issues that can happen, muscle pains. So you can have myalgia, you can have myopathy, you can end up where they're super bad and then they get rhabdo. And if you don't let them know what they're looking for, sometimes the patients will present and they're in rhabdo, which we don't want to happen, okay? So let them know, hey, if you start to feel any type of like myalgia, any type of myopathy, let me know, okay? So that we can go ahead and figure out how we're going to change your dose. That will be your sign for you to decrease their dose. Decreasing their dose can look several different ways, and we're going to talk about that in a minute, because I can say, I want you to take it every other day. I can tell you I want you to take it every 2 days. I can give you a low intensity statin. So there's several different ways for you to use that art and say, how do I want to manipulate this for my patient, okay? You don't need to remember the cutoff of the upper normal limit, all of that. I just want you to remember your side effects that you have. You have myalgia, myopathies, and you have your rhabdo that can happen to your patient. LFTs. This can definitely happen. We've had this happen to a patient. I think they were only on the statin for 2 weeks. Their LFTs shot through the roof. We had to pull back our drug. So rare, something that I definitely leave on there to make sure that you're monitoring it. So get it at baseline and at least at 4 weeks. And then you do it again. You just continue to check it. So baseline 4 weeks, 12 weeks is what we're typically looking at. How often can I increase my dose of my statin? 4 weeks, okay. So all I need you to remember from there is that first bullet. Don't need you to remember the 3 times upper limit, all that. I don't need you to remember that, okay? So our 2 side effects, my muscles, my liver is what I'm worried about, okay? This is a summary chart to give you like, hey, what am I monitoring, bless you, and how often am I looking at it? So I'm getting my lipid panel, of course, because that's why we're giving the medication in the first place. I'm going to look at my LFTs and I'm going to look at my CK. The reason why I'm looking at my CK is because I want to see what they are at baseline. But remember, my CK is what was telling me if I was going to have any increase of that rhabdo or any increase in the pain that they're feeling, okay? Now, you do not wait. If somebody tells you, hey, I'm experiencing muscle pain, you're like, well, I got your CK at baseline, I'm not getting that level again, good luck. We're gonna pull it, regardless of what time they come in and they tell you that. When they tell you that, that's the lab that you're looking for, okay? So you're gonna, any signs, any symptoms, and you're gonna educate your patient so they know what those signs and symptoms look like. So what we just tell them, like as a blanket, you have any type of muscle pain at all, I need you to call us. And that's what we tell our patients. I don't try to distinguish all of the different, if you have any muscle pain at all, let me know. Because when you try to talk to them, they don't look at you like, how y'all be looking at me? Okay, looking at what can help or what can induce or cause my patient to be more likely to have these myopathies or these different characteristics listed here. So that's why when we were talking about our older patients, right? I'm more likely to experience those side effects. So that's why I was saying, hey, maybe you just let me live my best life. Maybe you say, okay, I'm not going to give you a high. Maybe I'll give you a moderate, or I won't give you a moderate. Do you want to try a low? At least I'm giving something in that situation. But that is going to be a discussion between you and the patient that's in front of you, right? They have to have buy-in on that conversation. If you see that they're starting to experience symptoms, just pull them off. Especially at this age. Here are some other characteristics of when we're likely to see an increased risk in our patients having the myopathies. And then looking at this is just talking about your statin properties that are kind of associated with those and why you see more issues in these patients who may have renal insufficiency, or women typically carry more fat. So that's why you're kind of seeing some of that stuff. I don't need you to remember all of these things. Just understand that there are things, the older that someone is, and their diet, we're going to talk about their diet, how that can influence things. Those are the two bigger things. So this is what we kept talking about. If somebody has that statin intolerance, they're experiencing a lot of pain, they're experiencing side effects after they have taken their medication, and you're trying to say, hey, what do I need to do to help you, right? What way can I get you to take some medication for your cholesterol and not have to experience any of that muscle pain that they're experiencing? So you're going to tell your patient, hey, stop taking your medication. You're going to pull your labs, you're going to look at your CK, you're going to pull LFT, you're going to pull everything, and do your UA to make sure that they also don't have rhabdo. And then if they're having mild to moderate symptoms, you also will tell them to stop until they can come back into you. But you see, you can also try to do some other things to like snoop and see if there's other underlying conditions that could be making them more prone to experience the myopathy that they're experiencing. You can also lower the dose. You can also try to change around how frequently they're taking it. There's several different ways for you to do that. So with this, with your mild to moderate, you're kind of being creative in your approach to still getting them to take that statin. But if I ask you this, it'll be, hey, they're severe or they're mild to moderate. What are you going to do? My severe person, they're stopping it, I'm doing my workup. My mild to moderate, I'm stopping it and I'm doing a workup, more so digging for other things that could be potentially happening. But what you don't see here, you're still going to pull those labs. You're still going to check that CK, right? Because on my chart, I was telling you, even if I tell you I have symptoms, you still need to check that out and make sure that's not what's causing my symptoms, okay? Now, my PK parameters that could affect my statins and how they're working, if I'm accumulating them, if I'm experiencing more side effects. So when you're looking at this, you see that you do need to dose adjust, so not bless you, making you remember any of that, of course. Just know that if your patient's renal function is declining, you're going to go into LexiDrug and you look it up. And it will tell you how you're going to dose that patient. What I want you to remember, bless you, is your atorvastatin and your pitavastatin. That's why I was telling you to look at that one. You don't have to renally adjust. So these are your drugs of choice in your patients who have any type of renal issues, renal failure. These are our drugs that are more likely to work. I don't have to do so much work. Okay? Atorvastatin, pitavastatin. Protein binding. Remember when we bind, we're in a relationship, right? All of our statins like to bind. The only one that does not like to bind is pitavastatin. Pitavastatin does not want to protein bind. Okay? So I guess the way that I would think about this, or if I were to ask a question on something like this, would say, like if you have another highly protein bound drug, what is a potential interaction that you could see if you had simvastatin or one of your other statins on board outside of pitavastatin, okay? So like thinking of it in that way, because it's going to displace that other drug. I don't expect for you to remember what is going to be highly bound. I will tell you what is highly bound. Yes?
This is the, is it pitavastatin or pravastatin?
Sorry, pravastatin. Pitavastatin was my reading. My bad. Y'all, I'm running today. My bad. Pravastatin. Sorry. Okay. Contraindications. When we talk about this, we say absolute and we say relative. When we're saying absolute, that means you absolutely cannot do it. When you say relative, that means like, I might have to change something, right? I might have to be creative in how I'm going to dose this. Maybe I have you take one in the morning, one at night, like one drug in the morning and then try to take the other one at night. You try to be more creative. You avoid it if you can, and if you can't, you say, how can I work with this? So when you're looking at your absolute contraindication, somebody that has that liver disease, so think about any type of liver, hepatic issue, we are not going to start this medication. The other condition that we absolutely don't start statins in is my pregnant women. Okay? So that's the thing that is not on there, but we talk about with your statins. Most of our pregnant patients, we're going to tell them, no. I don't need you to read this whole thing down here. What it's saying is this is like a risk versus benefit thing. If you have a new person who may need a statin, you are not going to, most of the time, be the one who starts that. Y'all will end up referring them. So what I want you to remember about statins is that we do not use these in our pregnant patients, in general. Okay? Your relative contraindications, anything that's going to induce or inhibit your SIPs. Again, like I always tell y'all, I don't need you to remember which ones. Just understand that we have different indications into which some of our other drugs may make our drugs work too much or too little. Okay? So inducing or inhibiting. Looking at my drug interactions, there are several drug interactions that can happen. We also worry about food sometimes as well, especially if somebody loves a lot of grapefruit. So if people eat a lot of grapefruit, drink a lot of grapefruit juice, you can see where they have that increased risk of myopathy. So when you're looking at this, just be very aware that like, one, they have to like eat and drink a lot of grapefruit juice, okay? Like, I'm talking about very substantial amounts. But we always caution people with this, so make sure that you just let them know. You see that your atorvastatin, lovastatin, and simvastatin is going to build up a lot more, and therefore you're likely to see more of that myopathy occurring because of that. Then you see your cytochrome P450 interaction. So again, all of our drugs interacting with those CYPs. What I want you to know is that your pravastatin and your fluvastatin are your ones that are least likely to have all of those CYP interactions. And then red yeast rice. I don't hear about this as much anymore, but this is a supplement that people can buy over the counter that has been that claims to reduce blood pressure, and some people say that it does effectively work. So just make sure that you're watching out for this, because there are interactions whenever we're looking at our red yeast rice with our statin medications. Again, just more side effects with the muscle pains, right? So more rhabdo, more myopathies that could occur if they're doing the red yeast rice with a statin, right? So those are three things that we have. Our pravastatin and our fluvastatin, we like them because they have less issues with our CYP. Your grapefruit juice, we are worried about our patients who are doing a lot of grapefruit juice, and we're worried about our drugs. are lovastatin, simvastatin, and atorvastatin if they are taking those, okay? Because we're gonna have decreased metabolism. If I have decreased metabolism of those drugs, their levels are increasing in my body. So that's why I see more side effects. More interactions that we have, this fibric acid derivative, you're gonna see this again. When we're looking at this, you're gonna see a lot of myopathy that you can have occur if you use both of them together. When you're looking at your gemfibrozil, because there's several different fibric acid derivatives that you can choose from, when you look at your gemfibrozil, this one is considered a relative. So thinking about that, we typically don't do it. You could see it, but it's not going to be because you did it. Somebody else is going to go in there that is managing that patient, and sometimes if they're not getting certain results, they will put them on the gemfibrozil with one of the statins, but they're watching them very, very, very closely for that myopathy. And then your niacin, you see here again that same increased risk of our myopathies, and then us worrying about our LFTs. And then you have all of your other medications that you see listed here. So your amiodarone, DILT, verapamil, so your non-DHP calcium channel blockers, and then you have your amlodipine, your regular calcium channel blocker. So when you look at this class, and when we talk about this class, what I want you to remember is that your biggest offender for increasing the risk of that myopathy with your statins is going to be your gemfibrozil. Okay. If you see them on this combination, then look and see who prescribed it to see if it was the same person, and then check on your patient, do your labs, see if they have elevated CK from their baseline, see if they have any type of muscle pain. Okay? If they don't, then you're okay. It's not like they're not gonna die from it. This is a summary essentially telling you all of the different interactions that we have, some of these that we already saw on the slide. I want you to know the agent that has the interaction, not the recommendation. So just look at our agents that are listed there. You're more likely to see the gemfibrozil being the one that causes the most issues with your fibric acid derivative. And your phenofibrate is the least one that we're worried about in that class. So don't worry about these recommendations where they're telling you don't exceed certain doses, all those things. That's for you to use when you're actually practicing. This is saying like, hey, if you do use this, this is the dose that you should max it out at, so that you're less likely to see that myopathy occur. Right? Let's just go to bile acid suppressants and then we can go. Okay. Okay, so our fibric acid derivatives, we typically call these fibrates. Again, another good class. What do we say our fibrates work on more? Triglycerides. Okay, so we went from our statins with our LDLs. Now we're looking at my preferred with me talking about my fibrates. What this mechanism of action is typically you have your PPAR, which stimulates lipoprotein lipase to break down or remove like your bad, your LDLs, all those chylomicrons that we were talking about. LDL, VLDL, they were moving all of these. So this is one of those meds, because of that mechanism, that is very, very good for lowering the triglyceride. As a byproduct, you can see that we also have the increase in our HDL, but again, not a reason as to why we're going to be prescribing it. This is one of the ones that is where we were talking about don't use your gemfibrozil with your statin. So we're going to do one or the other. Your gemfibrozil is the one that was the worst, and then this one is the one where you're like, like am I worried about it? Yes, but not as much as I am with my gemfibrozil. Okay. Your clinical use, just remember triglycerides, and then understanding that this could be something that's a good second line for someone who can't tolerate a statin, but not together. Okay. So don't use the statin in the fibrate together. You're using a statin. If the statin can't work or the patient can't tolerate it, then you'll go to the gemfibrozil. So think about statin as number one, gemfibrozil as number two. Looking at my adverse effects, The reason why we said we typically won't use my fibrate with my statin was because I have the increased risk of having that myopathy or that rhabdo. So that's why you see, again, that side effect listed there. The headache and the rash, we talk about headaches all the time. We talk about like nausea, vomiting things, right? So that headache isn't sufficient or a big deal. What we're worried about is some people who do break out and they have a rash, okay? And then looking at this GI malignancy, don't really worry about that. The evidence is all over the place, so just understand that you may hear it. Looking at our monitoring, we just want to make sure that if we are giving it with a statin, because remember we had those little caveats where you can see that. That's why I was telling you, look at their LFTs, look at that CK, talk to your patient, ask them, hey, are you experiencing any type of muscle pain? Pregnancy with this, you can see that you can use either of them in the second trimester. Make sure you're just consulting, okay? Like just, you can use it after your second trimester is what you need to remember for the exam, after second trimester. Drug interactions, you've already seen this, so this was the one where we were talking about our gemfibrozil with our statin, not combining those. You see that you have the fenofibric acid. That one was the one that we were saying was least likely where we were worried about the myopathy occurring. So that's why you see, hey, it's a little bit safer. So when you see the fenofibric or fenofibric acid, just understand that that's an option that we have. This goes on and off of our formulary because of how much it costs, and because of the evidence of if it's actually effective, more effective or not. So just when you see that, understand the way that I would ask you is if you see fenofibrate, then understand that that's less of an interaction with your statin than your gemfibrozil. And then your contrary indication that you have, again, any type of renal hepatic issue, we're worried about that. If they have any biliary issues, we're also worried in that situation. We'll stop here. Okay.